voice. Um, I'm gonna make my presentation in English, but I know French as my fifth language, so please feel free to ask your questions in English or French or other languages that I know too. So I'm gonna start with today's presentation without further ado, with disclosing that I have no actual or potential conflict of interest to this talk and acknowledging the funding agencies and organizations who support my research lab. So I'm going to give a brief introduction onto the research focus area in my research lab, and then I'm going to present more on my research in older adults care. So in my research lab, I have four main areas that I focus on that we are doing research and training on. The first one is the disease prevention. So we are focusing on prevention of different type of disease and more specifically on cardiovascular disease among women, older women as well. We are developing models, evaluating them, developing AI models and also other advanced technologies for prevention of cardiovascular disease. The second area of focus in my research lab is older adults care, where we are developing interventions and models and technologies for early detection of conditions and also for promoting independent living and well-being, which I'm going to present more in today's presentation. We are also focusing on responsible development of AI models or responsible AI, that's called. So we develop frameworks for mitigating the bias and consideration of equity, diversity, and inclusion. For instance, our recent framework on how to integrate EDI in the AI lifecycle is recently published. It's called EDAI. So if you're interested, you can take a look into that. And we are also focusing on trustworthiness in AI and how we can make sure that the AI models that we're developing are transparent and explainable. So that's explainable AI models that we are working on. And lastly, we are focusing on medical education in my lab. So we're developing frameworks and also trainings for medical students and residents. Our recent curriculum framework for teaching AI, teaching and learning AI among family medicine residents is recently published, which is called AI FMed. It's recently accepted, but will be published very soon, which is called AI FMed. So with that being said, in my lab, we are also collaborating with different stakeholders beyond academia. We're collaborating with industries. In the past, we have been working with Ariel, which is a company, technology company, motion for the sensors and motion detection sensors. They've been working with Roche Canada during the pandemic. And also we are working with different healthcare providers and clinics, including George General Hospital. I'm working there as well. And also other hospitals like St. Mary's Hospital. And closely collaborating with patients. So we have patient partners involved in our project from the beginning to make sure that the technologies that we are developing are in line with their needs and is in line with their needs and what they would like us to develop. So this is a picture of last October that we had a workshop in Switzerland, Geneva, on use of AI for promoting health equity, where we had collaborators from WHO, patient partners, clinicians, primary care providers, as well as pediatric surgeons at different levels, and also researchers and AI experts. So it's a really collaborative research that I'm interested to do, involving all of the different stakeholders and collaborating and developing technologies for the benefit of our patients. With that being said, in today's talk, I'm going to focus on the older adults care and the work that we are doing in the research lab. So I'm going to start with the importance of why it is important to provide care to the older adults. Based on WHO's report, by 2030, 1 in 6 people globally will be aged 60 years or over. And this is expected to be almost doubled by 2050. In Canada, as of July 1st, 2024, there were 7 million persons aged 65 years old or older. And this is the stats that we are seeing in terms of the about 20% of our population in Canada is 65 years old or older, which is an important portion of the population that we have here in Canada, and majority of them are living in province of Quebec, where we are doing research and providing care. So it's very important that we focus on this type of research. And these, for sure, this older adults population, as we are seeing increase in terms of older adults population, it leads to the demographic shift. It changes that has an impact on economical aspects, social changes that we are seeing in the structure of families and patterns of work and retirement. It has an impact on policy development and healthcare changes. So, but considering all of this, we know that during COVID pandemic, Canada's healthcare system has been proven that it's not well prepared for serving this population properly, specifically at CHSLDs and long-term care facilities. We saw that this was not the services that is being provided for the older adult is not in a high quality level. And majority of the mortalities and the spread of the disease has been happening in these long-term care facilities. And the key issue that they identified was in these long-term care facilities, as well as home care that we are providing for these older adults, among others. So with that being said, we know that the technological advancements could help us to create a new opportunities for better care, to provide better care for these older adults. However, these technologies are costly, and we are seeing a significant technological gap in our healthcare systems and its use, despite that they are well developed, despite that they could help a lot our healthcare system, but we are not using it properly. So how AI could help, or how could AI-enabled technology help us to provide better care for our older adults? So I'm going to give some examples, but the use of AI technology or AI-enabled technology goes beyond these few examples that I'm going to give. These are some examples that we focus in my research lab. So one example of using this technology is that we can continuously track vital signs and detect health anomalies in real time using wearables and AI technology all together. We can develop smart homes for our older adults to provide better care for them and monitor their daily activities. If there's some emergency that's happening or fall for older adults, they can detect it as early as possible and inform the caregivers or emergency services in a timely manner. So in line with that, we a few years ago, with the support of Ministry of Economy and Innovation of Quebec, MILA, Quebec AI institution, Aerial Tech company, and McGill, we started this project that focuses on frailty and depression detection. So the aim of this project was to develop an AI model or machine learning model, more specifically, to monitor the physical activities of older adults continuously and hopefully to use these physical activities that they have within their home to be able to predict depression and frailty. So we collected as community dueling older adults. We recruited community dueling older adults in Montreal. We installed the Wi-Fi, the motion detection sensors in their home, So we were basically collecting Wi-Fi signals for 6 months, installed their home, so to track their activities, their sleep duration, the sleep interruptions that's happening in their home, their bedtime, and so many other factors. And also we collected their depression status using a geriatric depression scale or GSD, and also a frailty scale using Edmonton frailty scale, and also demographic information. So using all of these data that we collected, we developed two different models. One of the models for depression detections, which is called HOPE model, and the other one was for frailty detection, which is called AID model. So I'm gonna explain HOPE model, that is, we just submitted the proofread of this paper yesterday, so it will be out very soon. So it's about the development and feasibility study of the HOPE model that we developed. As I mentioned, we collected this information, the Wi-Fi data that we collected from these older adults home for 6 months, the depression status of these older adults, their demographic information, and also frailty status. And we developed our model, which focused on 3 stages. So we did feature selection, dimensionality reduction, and classification tasks using machine learning tools. And at the end, we added a layer for explainability of model to have better understanding of why this model is doing this prediction of this person having this level of depression or not. So it could help us to better understand the AI model. And this is the our model's performance. We compared our model with different machine learning, baseline machine learning models, including random forest, SVM, logistic regression, XGBoost, and mix of other models, which is called embedded models. And our model performed very much better compared to the other machine learning models. And you see here the confusion metrics of this model, which is mentioning that it detected the depression properly compared to the other scenarios. So now I'm gonna present the results for the explainability aspect of this models for the HOPE model. So we use 2 different explainable machine learning models called Shapley and Lime. Apology if the size of the photos are not bigger. So let me see if I can zoom actually here. Yes, perfect. So this is the Shapley model for the explainability aspect. So we wanted to know why our HOPE model is doing this prediction based on which feature. What is important for the model when it's predicting an older adult going to have depression versus not. And the aspects that we found, which is more associated with the model's prediction, was the sleep interruption, average sleep duration, and all factors were basically related to the sleep. And same thing happened for the other explainability model that we focused on. The sleep was one of the main factors that was having impact on the prediction of our model to predict if someone gonna have depression or not in this specific study. Yes?
Sorry, can I just one quick question? Is the model predicting the state of depression or the shift between healthy and depressed?
A state of depression. Okay. So we followed exactly the GDS category.
No, but I mean, it's not the shift in the habits, sleep habits. It's really the state of the patient.
Yes, exactly.
Which GDS? Which one?
I can double check that. I don't think college but I can send it to you the information. So There was one interesting thing that we found in this study, and I looked into the other studies that they published in the literature because our evaluation was purely based on prediction of machine learning. So we didn't know clinically if it makes sense that sleep is related to depression among older adults. I was curious to see if what other published clinical studies say about that. And I looked into the literature and I found a couple of the studies. One of them is recently published in January 2025 that they found association between poor sleep quality and depression symptoms among older adults in different countries. And it was very interesting to see this because our AI model didn't know that.
Your model is tree-based because why you are using Lime or Sharp? Is it based on what kind of tree-based?
Yeah, it's basically the last stage of the model that we wanted. We basically collected the data. We developed our model, did the data processing, feature engineering, and developed our whole model. And in the last stage, we looked into the explainability. So we did the explainability analysis to have better understanding of why this model is predicting this this states of depression, what is based on this model. So to just break down a little bit black box nature of these AI models. So we just wanted to have better understanding of the prediction that are being made. That's why we did the explainability analysis and explainability analysis. In the explainability analysis, we found that one of the main factors is sleep quality, the interruptions, the sleep duration, those factors, which was very important for the machine in the prediction stage. Okay, so that was one of the projects that we conducted in my research lab on the depression detection among older adults. We also did study other applications of technology, including AI-enabled robots and its impact on early detection of Alzheimer's disease. Of course, this was basically the review studies, systematic review studies that we did, but this is something that we want to start and study further for the future because we found very interesting results from the previous published studies in terms of use of humanoid robots and which were empowered by AI technology to detect Alzheimer's disease, more specifically based on the communication that these robots have with the older adults. So basically the breakdown of how these humanoid robots are being used for patients with Alzheimer's disease, so to assist them with daily life support, for cognitive therapy and cognitive assessment. The subcategories of daily life support, which I won't focus in this talk. But I have a question here now for you. So how do you think that we can effectively integrate these technologies into policies and into real clinical practice? How we can use these technologies responsibly and why? So we know that these technologies are, some of them are well advanced and are ready to be studied further and integrated in our clinical study, in our clinical practice, but how we can make sure that they are integrated into practice properly, which is the place that they can make an impact in real life, right? If we are developing this technology but not implementing in real practice, what's the point of development and testing these technologies? So what do you think could be important factors?
I think one is working with the practice sectors also together from the beginning to try to understand what's the problems and the barriers.
Yeah, absolutely. And then I have another question for you. So do you think older adults versus younger adults, so if you want to compare older adults versus younger adults, which one is more comfortable with use of AI in healthcare.
You want an answer based on stigma and ageism, or your real answer?
We're too aware to answer.
I just see two chat messages here. One comments in terms of acceptability and time constraint, financial concerns for the previous questions. Thank you. And any other thoughts on this question?
Just a thought that sometimes older dogs, they're different, they might have different opinions about these and different attitudes towards AI. Not all of them, maybe there is, bias for one or other, but it's like very heterogeneous, I think. So yeah, that's just my thought.
Based on Facebook, AI is probably more popular with older people than younger people.
More popular.
More popular.
Maybe less resistance.
Because they believe it's real.
I'm very happy with your answer, because it was very close to what this study found. They conducted a study in terms of exploring differential perceptions of AI in healthcare among younger Canadian adults versus older adults. So they conducted a very comprehensive survey study with over 12,000 older adults and younger adults, and they aim to see what is the level of comfort and perceptions around adoption and use of AI in healthcare setting. And the result is that, however, so you see here in this figure, the blue one shows the younger adults' response, and the orange one shows the older adults' response. So, however, younger adults have more knowledge of AI and how it could be used in healthcare settings, but this study showed that older adults has more are more comfortable on use of these technologies in healthcare setting, which is sometimes surprising for us. Not here, but in other settings, maybe they feel that, okay, older adults may not be that comfortable using AI technologies.
Can it be that older adults, they have more experience in healthcare and the problems with healthcare, so they will be more open to, and younger adults?
Yes,
I don't know.
That might be one of the reasons. So that's why we started digital ageism studies, and we wanted to study this and make sure that we are considering age bias in AI technologies properly. So we always have misconception that older adults are homogeneous group of people who are inclined, incompetent, and need younger people to when it comes to the use of technologies. And that's why we started this project with colleagues from University of Toronto and University of British Columbia, on which is funded by SHIRK, on use of or handling or tackling ageism bias in AI algorithms. So in this study we presented this framework of injustice or cycle of injustice in digital technologies that results in digital ageism. We discussed different aspects, including the way that we are designing these technologies are ageism, the data availability are different, and we're excluding older adults most of the time from technology purposes. The data that we are using to build these technologies are also unrepresentative. Most of the time, the representation from older adults is that older adults as unhealthy and technology illiterate, while it's not the case, and that shows that that the data is not comprehensive enough in development of this technology, and we are not providing the similar resources and access to the technology for older adults as well as for the younger adults. So it's a lot that we have to consider to promote inclusive design practices of these technology, including AI technology for older adults. and encourage interdisciplinary collaboration between different stakeholders and involving caregivers and older adults in the design and implementation of these technologies. And that was very interesting because after we published this study in 2022, the WHO published a similar sort of like another recommendations on ageism in AI. And why it is important to consider age biases in AI technologies. This is also another study that you see here. We looked at, it's a review that we conducted on use of and the AI algorithm and if they are biased towards age. And we found that majority of age recognition and facial recognition technology are biased towards age, which is something that we have to put more focus on and improve this technology to make sure that they are not biased towards age. And majority of these biases happen from data collection to algorithm development and algorithm development to implementing it in real practice, not in the algorithm development stage, but more in the data stage and in implementation stage. So I have another question for you. So what do you think is the most important factor that affect on technology acceptance and adoption of older adults, more specifically on AI and older adults and caregivers and their caregivers? So what do you think it could have the most influence in the adoption of these technologies?
Just a question, maybe I don't have it, because when we talk about technology and then technology and AI.
No, more specifically AI technology.
Yeah, because when I think about AI technology, I think mostly like we don't even have control of that. So if I'm using like a cell phone, there's a lot of AI there. But so it's just I'm trying to think about the difference with using technology and technology with AI. If there is a difference, because we have AI, or technologies, but we are not aware it's just there and we don't know. So just
So what do you think that have an impact on their acceptance or use of this AI technology? Their time and trust. Yes, trust is also a very important factor.
It's generally a combination of factors, I would say. If we look at the models for technology, not necessarily with AI, we know it's a very complex interrelation between perception of their needs for technology, social influence, caregivers, clinician influence, usability, and so on. So I guess it's probably the same for AI.
So it needs an AI model to explain what are the...
Yes, that's also very interesting. But we conducted actually a study on acceptance of AI among caregivers on use of these AI technologies for providing care to their loved ones. So we wanted to have better understand the factors that influence the family caregivers' behavioral intention to use these AI-enabled technologies. We looked into over 200 Quebec middle-aged family caregivers who provide care to older adults. We used online cross-sectional survey study, which was based on Unified Theory of Acceptance and Use of Technology Framework, UTAUT. And we used AI to analyze the results, or more specifically, random forest model to analyze the results. And so it's very interesting. As mentioned, different factors had impact, but one of the most important or strongly influenced factors was social networks, meaning that if the caregivers of older adults see that their colleagues, their friends, their close network are using specific AI technology, it has more impact on their intention of using that technology themselves as well. The social networks was one of the influential one that we found in this study.
How did you quantify by connections? How did you put it in the model as predictor, the social networks
Yes.
parameter?
Yeah, we consider different factors, including trust, social influence, technology anxiety, cost, confidence in the source of advice they receive, different factors, which was based on UTA-UT, it was a modified version of UTA-UT framework. And then we analyzed it using random forest to see which one has the highest impact on their intention to use this technology. I mean, so social networks as the most influential factor, was the most influential factor.
Coming back to this question, so how did you quantify social networks? So how?
Yeah.
Oh, we didn't look like in deeper factors of what social networks was, but the question was if your families or friends are using this technology, how would you, does it have an impact on your intention?
Binary factors.
Yeah, exactly. We didn't look into the social network itself.
But there is a way, because we can quantify the number of links or the number of.
Yes, absolutely.
I think we have to.
Absolutely. No, this was actually a master's project for one of my students who was doing her master's in family medicine. So we had limited time to finalize our master's, so we didn't go to the next level. We just looked into the influence and how strongly or not strongly influence these factors. And also we looked into the globally how this technology adoption and use. This study more specifically focused on technology, not specifically on AI. This was a collaboration that I was involved as co-investigator with my colleagues. It was a collaboration between Canada and Belgium. That the goal was to see the factors influencing technology adoption and use among older adults with MCI or dementia. So we looked into Belgian community dueling older adults diagnosed with MCI or dementia, their formal caregiver and their informal caregivers. So we conducted a semi-structured interviews with them and also focus group with these participants. And we identified different factors, 3 types of factors that could affect that on technology adoption and use. One of them is the personal attitude and beliefs of those people on using this technology. The second one was usability and design of technology, which was an important factor. And the last one was support from family and friends. How much support they receive from family and friends on using this technology, which was had a factor on that. I just brought this an example as an international study that we did in another country, and somehow some aspects of that has been mentioned in this study was also very close to our study here in Canada, in Quebec. So lessons learned from these studies is that developing AI system that can better understand, respond to the complex needs of older adults is important. So we have to make sure that we are designing these AI technologies with older adults and then validating and implementing them with them. It's very important to not exclude them, making sure that our technologies, our systems are according or based on their needs and are not biased. Second important aspect is that we have to make sure we are responsibly using these AI technology as much as possible. We are making them transparent and explainable as much as possible. So based on my experience also in this AI healthcare context, I found it very that in the healthcare settings more specifically, AI technology are needed to be explained why this tool or this predictive model explained this. And this is important both for patients and for clinicians to have better understanding. So it's very important to focus on transparency aspects and make sure that these models are fair and not biased. And privacy aspect is also for sure important factor. And third thing is that we have to make sure that to facilitate their adoption in the real clinical practice where they have a real impact. And one important aspect is that we focus on usability and user-friendliness of these technologies. So we have to make sure that these technologies are designed in a user-friendly way. And again, it is designed with end users. And lastly, the collaboration and the interdisciplinary and multidisciplinary approach, I found it's very important. So that's why I'm always open and eager to do multidisciplinary collaboration with different stakeholders and involve different stakeholders as much as possible to make sure that we are including everyone from the early stage of the development, not the last stage. There's a lot of AI models, AI systems that have been developed and then they have been just pilot tested with end users at the end stage, which I don't believe is the good practice. I think the best practice is to start from the beginning with all of the stakeholders involved. So with that being said, I'll finalize my presentation. Thank you very much for your attention. I'll be happy to answer any questions you might have.
Are there any questions online? Est-ce qu'il y a des questions
I don't see any. Des gens applaudissent.
Applaudissent. Okay, so we'll start with questions on the room.
I have a question. I'm sorry. It's just because you said that you used ADI. I don't know the terminology to explain the models. I don't know the terminology to use, EDI. For example, in the study of the hope for depression, was it incorporated there, like this ADI model and how?
A very good point. We consider responsible AI aspects in the hope model, but in that when we were developing hope model, EDI framework was not developed and ready yet. We published it a few months ago. So EDI framework is recently developed and published, but the hope model has been developed 2-3 years ago. Before we had that EDI framework to follow, we did our best to follow responsible AI development steps as much as possible based on the ethical AI frameworks that were available by that time.
Would any change be made if ADI was considered?
That's a very good point. I think for the future studies, we have to focus on more minority communities. We didn't have opportunity to involve more older adults from minority communities in that study. I think that's something that we have to study further, and it's very important.
I was just wondering if you're trying to separate your older adults in two groups with the younger, older, and the older, and if you see any difference.
Yeah. A very good point. We are trying to do that in the cardio twin project. It's another project focused on cardiovascular disease among women. So we're looking into younger, older adults and older adults for early detection of cardiovascular disease and prevention of it among them. We didn't do that for the HOPE model or AID model. That's something that we would like to consider for the cardio twin project, and very important factor. I think it's specifically on cardiovascular disease, early detection, it would have an impact.
And related to that, maybe the use of AI, do you think that very soon the difference between young and old will be less important because we kind of grow up now with this, or maybe there's just always some new technologies and there will always be a difference?
Very difficult question.
20 years from now, we are going to be older adults.
20 years. Well, what do you think?
Yeah, we should ask AI to predict that. But that's also a very good point and difficult answer as AI advancement is super fast. I'm working on AI models, and that every week there are thousands of work out there, new models, and specifically with the large language models that has been advanced very fast in the past few years with the ChatGPT and GPT models and transformers. It's very difficult to catch up, even for us as researchers. So I don't know how older adults and our patients and clinicians will catch up soon. For sure, we gotta find a way to do that.
Yeah, but we're also in a good position to see in what conditions these models could be helpful and validate the impact they have.
Exactly.
Did you mention the biases? Do you have a categorization of the types of biases that AI models would have in the context of health and aging?
On aging, and I'm not aware of any studies, or we didn't look into on aging, but or general on AI in healthcare, yes, there are some very good studies that are published on different biases that does exist. And one of the bias, for instance, goes to the historical bias that we have as humans when we are developing our models. For instance, association of the HIV with the LGBT community, this historical bias that we have, or the data bias or data represent the sample bias that we are seeing. The data is not representative, so that's also another bias that could exist. The algorithmic bias when the person is developing the algorithm, it also could impact on the bias or the outcome, biased outcomes of the algorithm. So there are different biases that does exist. I'm not aware of any in aging. Maybe we should
I'm
discuss
aware
this
of
further.
one.
Yeah.
I'm working on pain perception and pain expression, and in the decoding of facial expressions, of course, the fiducial point on the face may be affected by the wrinkles in your face, and of course there's a racial bias in AI models of facial recognition. There's a cultural bias and emotional expression that varies between cultures. So there's in facial expression there are many sources of biases that would affect the detection and classification, discrimination of emotions in older adults.
Exactly, and that's also something we found in our study on AI biases that exist in AI systems. Facial recognition systems was one of the most biased towards age. And that's something that needs to be improved.
But I'm thinking also that the HOPE model where you find that the sleep habits have a large factor. We know that aging will potentially eventually affect your sleep cycle. So how much of this is embedded in the model, and can it discriminate between sleep signs of depression in younger adults, older adults? That's why I was asking also about the change, because one of the key features in clinical research or in clinical practice is the change. When something changes that is meaningful, significant, then that's a sign.
Especially when you use the GDS as a scale, because it's not a diagnosis, it's a tool to support the difficulties to identify depression in the older adults population. So GDS can be positive for other reasons than depression, and especially cognitive impairments. So comparing, your model is not predictive of depression, maybe of risk of depression, but not depression. So it's interesting to have in mind when we use a tool what is the purpose of this tool? And the purpose of GDS is not to diagnose depression, but to support diagnosis of depression based on other issues, and sometimes it's difficult to use. So probably the type of tools and data that is used for the model has to be considered as the bias tool, because GDS is not depression.
Yeah, so I think for that study, we need to do larger studies and use this model. It was because it was a feasibility study that we did. It's just those to start to get it started and build the initial model and then improve it.
Yes, which is great. I mean, but probably the second step is to
do it with a larger population
and compared to differential diagnosis, especially on this stage, aging, Alzheimer's, or related dementia. And what is true is that depression impacts sleep phenomena. So,
We have a question online from Alexander Moreno.
Hello, Dr. Rahimi. Can you hear me?
Yes, yes.
Thank you for your excellent presentation. I have two questions. For the study about depression, yeah, I would like to learn more about the sensors that you were using and exactly what you were trying to measure in terms of behavioral indicators of depression. And for the second question, we know that a lot of these technologies intended for older adults and family caregivers do not have, there is not a lot of evidence about their use. So, what is your opinion about that? Thank you.
Sure. Thank you very much for your question. Excellent. It's great to see you here virtually. So, in response to your first question about the technology, so we've been collaborating with an industry partner who have been developing these sensors, motion detection sensors, for quite some time, and we collected the data using these sensors. The company is named called Aerial Tech Company. It's also McGill-based startup that they started these sensors. So we were studying this using their sensors. For your second question, can you clarify a little bit about your second question?
Yes, it's about the efficacy of this technologies designed for older adults. I'm particularly making reference to a systematic review that we published recently, showing that there were just only a few in the past 10 years, showing efficacy, and none of them had moved to the large-scale implementation stage. So, what would be your opinion about this, and maybe what is happening in terms of going or moving forward to large implementation with these technologies?
Excellent point. I absolutely agree with that. It's in terms of the efficacy study, I believe there is not much studies has been done, and more needs to be done, because we also did a study on use of AI technology in primary healthcare and how many technologies had been developed and how many went to implementation stage that we can evaluate them properly. And over 95% of the studies that we looked into was a huge study that we conducted in this area. We looked into the old literature, and over 95% of the studies focused on development of these technology and pilot testing them only. They didn't go to the implementation stage or even look into the efficacy aspect of it. So I think it's an area that we need to study more, and in order to study in a larger scale, it's that we have to start with a small studies, pilot tests, and continue the use of those technology and bringing to the clinical practice, conduct larger studies, and we shouldn't stop in the pilot testing stage. I think it's an important factor that we have to consider. But thank you for bringing that up. I absolutely agree with you.
Thank you very much.
Thank you for your comment. I had a question, because how many of these biases that you're finding do you think are specifically related to AI technologies that are being used for older adults, versus just most technologies being developed for older adults, regardless of whether there's a deep learning or an algorithm within it? Like how much of that is a bias of the AI being present, or just the way that we approach developing tech for older adults?
I can say both of them based on the studies that we did, but it's again depends on the specific context that we are looking into. For instance, in the facial recognition aspect, we know that the technology are not well developed because of the data sets are biased. They published a few years ago in terms of these facial recognition technologies biased with regard to the race. And recently also they published with regard to the age. So I believe it's more consideration of different factors at different stage, from data collection to algorithm development and implementation aspects, that all aspects they have biases, and we have to make sure that we are considering comprehensive guidelines and frameworks, which also doesn't exist, but we have to work on that too, to make sure we have guidelines on following.
So your fear, which I think makes sense, would be that they would be more pronounced in tech that's being developed with these algorithms as opposed to the ones being developed without.
Sorry,
that the biases would be perhaps more pronounced because you can embed biases at all these steps.
But getting back
AI tech, in tech that involves AI.
Yes, I agree. And when we go back also to the data that we are collecting in healthcare systems, it's quite biased.
Preaching to the choir.
Yeah. So we have to expect that the algorithms that are being developed based on this biased data, which is a long-lasting problem, are also biased. So we have to start from the beginning, the first stage, the data collection stage, and how much inclusive we are in that stage.
Yeah. Thank you.
Yeah, but currently it's patches are added to constrain the AI models rather than, I mean, going back to the data is almost impossible because the data will always be biased in some way because of the large level, the amount of data we need to build those models. So it needs to be, I think that identifying those bias and then trying to correct the bias, or at least be aware of the bias so that clinical decisions are not influenced by those bias. But it's very
to your point, you're right that in fact, like a lot of these, particularly deep learning models and the ones that are really evolving quickly, like LMs, they're just trained on data of much younger adults, for example.
Yeah.
And so having a large data set that existed that one would build based on clinical data of an aging population next door would be, I think, of great value, particularly to a few community of researchers like this.
There's a plan.
There's a plan, something like that. But yeah, you're right. But of course, there's these challenges that we're never going to keep up with the ChatGPT on that level of data when you're just scraping the internet.
Exactly. That's something when I'm, presenting it also to clinics and hospitals. Like, what should they ask? What should we do? Well, start with properly collecting your data in the clinic to have less noise, to have more diverse data sets. I think we have to start at some point.
Working on the other side.
So agree. No, but
it's a project within the center. Just that's the undertone that you're picking up on.
But I want to point out that you mentioned less noise. And that's a discussion I've had with people who develop, or people who are more in the modeling part, where they have this illusion of being able to make sense out of the large set of data. Of course, the more data, the more you can manage the noise, but cleaner data is always better.
Yeah.
Any case. So I think that's
Absolutely.
a very important point that, garbage in, garbage out.
Yeah, I agree.
We have another question online. Go ahead.
It's just because it's been mentioned that we need to make sure that the clinician know about the bias I don't think it's part of the training that they know that it's possible to be able to know that. And when I see Plumia and Caraway and ID being used with patient during meetings, and I don't think people realize like the implication of this technology. And it is our part to make sure that they are trained and that it doesn't just start with people at school and university, but also for people that are working right now, and that it's interesting for them, talks to them, easy to understand.
I agree with your point. That was a great point to focus on educational aspect. And that's, I think, why it's important to we start the training with medical students as early as possible, with the residents, with even patients and public. This is something that is not being done. And I'm not saying that I started this communication with our continuous professional development office and medical education office to see if we can develop some sort of modules available about AI and what AI is and generative AI is, and make it available for our patients and public so they have better, at least at some level, to have better understanding of what AI and to reduce the biases and the misperceptions about what AI is. Because sometimes when I present to patients and public, also one question that I receive is that, well, a robot's gonna kill us in the future, and about killer robots.
Well, some of them.
That's what the media are telling us, like social media. I would just wanted to say that the Finland approach is really interesting. And in Europe, and you also have like a questionnaire where you can see what is your level of expertise on technology. And I really like also, and the Finland now it's available in French and in English, so it's really interesting. I can't wait for a solution like this for us.
Regarding education, at least in some departments in the Faculty of Medicine at the University of Montreal, I can speak for psychiatry and radiology. They're starting to think about not think about to introduce AI classes to their residents and trainees.
Yeah.
So I'm not saying it's as fast as it could be, but it's there are a lot of discussions on these issues.
That's great.
Yeah.
Time.
Well, thank you very much.
Thank you.
Merci, bonne fin de journée. Au revoir. Thank you.
Oui.
Okay.
Est-ce qu'on reste ici ou on change de